Welcome to the Hospital Medicine Unplugged podcast. Our mission today is to conduct a deep dive into Mallory-Weiss tear, or MWT, an uncommon but absolutely critical cause of upper gastrointestinal bleeding in our hospitalized patients. We've got a solid base of sources here looking at diagnosis and management. We really want to focus on telling the difference between those straightforward self-limited cases and, the higher stakes ones needing immediate action.
It's a really interesting topic in hospital medicine because MWT is fundamentally a mechanical injury. That changes how we think about it right from the start compared to, say, peptic ulcer disease. And while, yes, most of these tears actually stop bleedage in their own, the real challenge is spotting and treating that critical minority, those patients who have a much worse prognosis if we don't intervene quickly and correctly.
That's exactly it. Quickly identifying that vulnerable patient that's core to our discussion. Robust risk stratification and truly evidence-based management. Just so we're all on the same page, MWT is specifically a longitudinal mucosal tear right at or near the gastroesophageal junction. Getting that definition and the mechanism clear is pretty vital.
Precisely. And it's important to remember, while MWT is definitely on the differential for upper gastrointestinal bleeding, or UGIB, it's not the most common cause. The incidence is usually quoted around maybe 7.5 per 100,000 hospitalized folks in Western countries. We do consistently see it more in men, often presenting in their 50s or 60s, but the fact that it's mechanical, a tear from force, that really sets the stage for everything else we'll talk about.
Okay, let's dig into that mechanical aspect right away, the pathophysiology. When we think MWT, there's that classic story involving a specific kind of physical stress.
Yeah, the mechanism is pretty much about pressure dynamics. Specifically, a really sudden, massive increase in pressure inside the abdomen and also inside the esophagus. That rapid pressure rise is the main driver. Usually it's set off by forceful retching or vomiting. Just imagine those violent muscle contractions, stomach, diaphragm, trying to force things out. It generates huge shearing forces right across that junction.
It's like a trauma, essentially. Yeah. The lining just can't take that sudden force.
Exactly. When those pressures spike so fast, the mucosa literally gets pulled apart, causing that characteristic tear. And the location is pretty predictable too. Most often, you'll find it on the left lateral wall of the gastric cardia, just below the junction. Why there? Well, it's likely due to the normal anatomy. That area might just be more susceptible, maybe because of the angle of the diaphragm fibers or how the blood vessels run underneath.
And while we often think of really forceful vomiting, the source of stress, we shouldn't only think about that, right? Especially with high-risk patients.
That's a really crucial point. Yes, repetitive severe vomiting, say, from alcohol intoxication or bad gastroenteritis is common, but that shearing force can come from other things too. We need to think about sustained violent coughing fits. They generate huge abdominal pressure. Also convulsions, blunt abdominal trauma, and even iatrogenic causes, like maybe during an endoscopy if there's aggressive maneuvering or repeated flexing of the scope. The key is the rapid pressure change, not just the vomiting itself.
Okay, that leads us perfectly into the predisposing factors.
Yeah.
This is where we identify the vulnerable patient. These aren't just side notes. They can really dictate the whole hospital course. What makes someone susceptible?
Well, alcohol abuse is, without a doubt, the most common and significant risk factor. It's linked in up to maybe 44% of MWT cases. It's that classic association we all learned. Alcohol's impact is kind of twofold. First, obviously, it triggers vomiting and retching. Second, chronic alcohol use might also damage the mucosal lining over time, making it weaker, more brittle, and easier to tear even under less pressure. Some sources suggest heavy drinking causes chronic inflammation and maybe changes in the small blood vessels in the upper GI tract, making it prone a mechanical failure.
So it's not just the binge leading to vomiting, but the long-term damage to the gut lining itself.
Precisely. You're dealing with tissue that's already mechanically compromised. And speaking of structure, anatomical factors are definitely important, especially having a hiatal hernia.
Yeah, a hiatal hernia seems to pop up frequently in these patients. How exactly does that make them more vulnerable to tearing?
The thinking is that the hernia basically changes the normal protective anatomy there at the GE junction. Normally, you've got the angle of the esophagus entering the stomach, the sling fibers at the diaphragm. They act like a valve during pressure spikes. A hiatal hernia messes that up. It makes the junction less able to withstand that backward pressure from vomiting. We also see links with severe reflux esophagitis and other gastric diseases, anything suggesting prior mucosal irritation or weakness.
Okay, so beyond the structure, there are the systemic risks, medications, and crucially, coagulopathy. These can really push a simple tear into a high-risk situation.
Absolutely. Medication-wise, things like nonsteroidal anti-inflammatory drugs, NSAIDs, and aspirin are problematic. They can irritate the lining directly, making a tear more likely, and they interfere with platelets, which makes any bleeding worse and last longer. But underlying coagulopathy, whether it's from anticoagulants or more often from advanced liver disease, that's probably the single biggest predictor of a really severe, complicated course.
That makes total sense. These patients tear more easily, maybe due to other issues, and they can't stop the bleeding effectively, like a low-risk patient might.
Exactly right. Think about patients with cirrhosis. They often have low platelets. Their clotting factors aren't synthesized properly, maybe kidney problems too. Bleeding from an MWT in someone like that isn't just a local issue. It becomes a systemic crisis. That's why risk stratification has to weigh these systemic factors so heavily.
And we should definitely highlight another high-risk group, the dialysis patient. Why are they particularly vulnerable, even if the trigger seems mild?
Yeah, dialysis patients are kind of a perfect storm of risks. They have uremic changes in their gut lining, making it fragile. They often have platelet dysfunction, even if the count looks okay. This fragility means they can get an MWT from surprisingly mild vomiting, much less force than a healthy person would need. Plus, their underlying heart issues and the risk of fluid overload make resuscitation during a bleed incredibly tricky. They just don't have much physiological reserve.
So right from the start, when we suspect MWT, we're already thinking about these two groups, the lower-risk patient with maybe just transient vomiting versus the complex patient with cirrhosis, coagulopathy, renal failure.
Exactly. The aim is early risk stratification. The sources point out that predictors of a rough course are often there right at the beginning. Two big ones cited are, first, seeing active bleeding during the endoscopy, that's the ultimate decider for intervention. And second, a lower admission hematocrit. A low starting hematocrit suggests either chronic anemia or significant rapid blood loss before they even got to us. That combination signals urgency.
Okay, that leads us smoothly into the clinical presentation and how we diagnose this. We mentioned the classic teaching earlier, that two-step presentation.
Right, the textbook description is that sequence. First, non-bloody emesis, just stomach contents or liquid, followed by a second bout that is bloody, the hematemesis. The idea is the first vomit causes the tear, the second one brings up the blood.
But if we hang our hats on that classic sequence, we're going to miss a lot of these cases, aren't we?
Oh, absolutely. This is a really critical point that sometimes gets missed, that classic sequence. You actually only see it in less than a third of patients with MWT.
Less than a third, wow.
Yeah. In most cases, the blood appears right with the very first episode of vomiting. So we need a high index of suspicion for MWT in any patient with hematemesis after some kind of recent physiological stress, regardless of that sequence.
Okay, so besides the vomiting, what other symptoms might point towards a GI bleed here?
Well, other signs of bleeding are pretty common. If it's a really brisk bleed, you might see melena, dark, tardy stools. Less commonly, if it's really severe, you might even see bright red blood per rectum, hematochezia. Patients might also mention some epigastric or retrosternal discomfort, kind of a pain or a pressure that came on before or during the bleeding. That fits with the mechanical stress and the tear itself.
And when we get to the physical exam, the findings might not be specific to MWT itself, but they're crucial for gauging how much blood loss has occurred.
Exactly. The exam is all about assessing for hemorrhagic shock. Key things are pallor, looking pale, and persistent tachycardia, a fast heart rate. We absolutely need to check for orthostatic changes right away. Does their blood pressure drop or heart rate jump up when they go from lying to sitting or standing? At the severe end, you might see signs of actual hypovolemic shock, orthostatic hypotension, or just frank low blood pressure. That happens in maybe 2.9% of cases, and it means immediate aggressive resuscitation, likely ICU admission.
Since the symptoms overlap so much with other causes of upper gastrointestinal bleeding, this brings us to the diagnostic gold standard: early endoscopy. Why is this step so essential?
Upper endoscopy is definitive for a few key reasons. First, obviously, it confirms the MWT is there. We can see the characteristic single longitudinal tear, usually on the stomach side of the junction. Second, and this is critical, it lets us rule out other potential bleeding sources. And third, it's our primary tool for risk assessment right then and there.
Tell us more about that risk assessment part. What are we looking for on the scope that changes the plan immediately?
We're looking for active bleeding, anything from arterial spurting down to just active oozing from the tear. We're also looking for high-risk stigmata. These stigmata include things like a visible vessel sticking out at the base of the tear, or maybe an adherent clot stuck firmly onto it. Finding active bleeding or these high-risk signs tells us immediately This patient needs endoscopic intervention. They're no longer in the watch and wait category. The scope findings really drive the urgency.
And that need to differentiate MWT from its mimics underlines why the scope is so necessary. The presentations can really fool you.
They absolutely can. We have to distinguish MWT from other common UGIB causes, like peptic ulcer disease, PUD. Both can cause hematemesis, sure, but PD often comes with a history of chronic dyspepsia, belly pain, maybe pain that wakes them up at night. That's pretty rare with MWT, which is usually acute, mechanical, after a specific trigger.
Okay. And how about esophagogastric varices?
Varices usually occur in a different patient profile. You're typically looking for someone with stigmata of chronic liver disease, like ascites, fluid in the belly, maybe known coagulopathy. Endoscopy confirms it by showing those dilated veins, but the clinical picture usually points you that way even before the scope.
Then there's Dieulafoy's lesion. That one can be tricky to spot, right?
Very tricky. A Dieulafoy's lesion is basically a single abnormally large artery just under the mucosa that's eroded through a tiny defect. It usually causes massive, often recurrent bleeding without any obvious ulcer or tear around it. It's critical to tell it apart from MWT because treating a Dieulafoy's often requires specific techniques, like thermal coagulation or banding, aimed right at that rogue artery, which is different from closing a superficial tear. We also rule out rarer things, hemobilia, aortoenteric fistula, severe erosive gastritis.
And here's a stat that really highlights the need for endoscopy. The sources say up to 35% of patients with an MWT might also have another potential bleeding source found during the scope, maybe an ulcer nearby or bad esophagitis.
That is a really striking number. It absolutely cements endoscopy as the essential diagnostic and risk stratification tool. We can't just assume the tear is the only issue, especially in these complex, high-risk patients who often have multiple GI problems going on.
Okay, so once we suspect or confirm MWT, the critical next phase is initial hospital management and stabilization. Let's focus on those immediate steps.
Right. Hemodynamic resuscitation is priority number one. You need immediate large bore intravenous access, ideally 2 lines, so you can give crystalloid fluids rapidly. That's the foundation. Restore perfusion, get the blood pressure up while you're getting ready for definitive control of the bleeding.
And when it comes to blood products, specifically transfusion, the approach has really evolved based on evidence in GI bleeding, hasn't it?
Yes, definitely. We now generally follow a restrictive transfusion strategy. It's about balancing oxygen delivery against the risks of giving too much fluid, especially in patients with cirrhosis. For most patients, the recommendation now is to transfuse only when the hemoglobin drops below 7 grams per deciliter. The target is usually to get them up to between 7 and 9 GDL post-transfusion. This restrictive approach has actually been linked to better outcomes, lower mortality, less rebleeding in patients who aren't having absolutely massive hemorrhage.
But we do need to adjust that target for certain people, correct?
Yes, that's important. You'd use a more liberal threshold, maybe transfuse earlier or aim higher, like closer to 9 or 10 GDL for patients who are bleeding massively, or those who have significant heart disease, like active coronary artery disease or severe valve problems. They just don't tolerate anemia well. So the decision has to be tailored based on their stability and underlying cardiac risk.
Now, let's talk about coagulopathy again, that major factor driving severity. Correcting it isn't just a good idea, it's often essential for any intervention to work.
Correcting coagulopathy is absolutely non-negotiable, especially before or during endoscopy. This means stopping or reversing anticoagulants if it's safe to do so, and giving specific products. For instance, if they're low on clotting factors, maybe fresh frozen plasma, FFP. If their platelets are low, give platelets, vitamin K if appropriate.
And those specific targets for patients with advanced liver disease, those are really worth remembering.
They are critical. For cirrhotic patients with active bleeding, you need to be aggressive about optimizing their hemostasis. The specific targets are: keep the hematocrit above 25% note, hematocrit, not just hemoglobin, get the platelet count over 50,000. And, this one's often overlooked but vital, keep the fibrinogen level above 120 milligrams per deciliter. Fibrinogen is essential for clot stability, especially when the whole clotting system is impaired.
And the moment we identify these really complex patients, the ones with cirrhosis, the ones on dialysis, the level of care needs to ramp up immediately, even if they look stable initially.
Absolutely. They typically need ICU admission for close monitoring. Cirrhotics particularly benefit from prophylactic measures. That includes giving thiamine to prevent Wernicke's and antibiotic prophylaxis because their risk of spontaneous bacterial peritonitis goes way up after any GI bleed. For the dialysis patient, like we touched on, the close monitoring is all about preventing volume overload and heart complications during fluid resuscitation. Managing these coexisting problems is often tougher than dealing with the tear itself.
So thinking about timing, when do we shift from just observing, expecting it to stop on its own, to deciding on urgent intervention?
Well, the reality is most MWTs, maybe 80% to 90%, do stop bleeding spontaneously. So for low-risk, stable patients, conservative management with observation and supportive care is the initial default. However, if the patient has active bleeding seen on scope, if they have those high-risk stigmata, or if they remain hemodynamically unstable despite initial fluids, then they need urgent preparation for endoscopy. You don't necessarily wait for them to be perfectly stable if the tear looks like it's actively bleeding or high risk. You stabilize them enough to safely get the scope down and intervene.
That urgency takes us right into comparing the different endoscopic and medical strategies for stopping the bleeding for good. Let's first just reinforce that threshold for intervening.
Right. So if the tear isn't actively bleeding, if it has a clean, white base, maybe a small visible vessel that isn't bleeding, or a firmly stuck-on clot, those are generally managed conservatively. You observe them, give supportive care, use acid suppression like PPIs. The risk of rebleeding in those cases is pretty low, and doing an intervention might carry more risk than benefit. Intervention is really reserved for actively bleeding tears.
Okay, so when intervention is needed for active bleeding, what does the evidence favor? We've got mechanical options, injection, thermal.
The evidence strongly points towards mechanical methods as the first-line choice for active MWT bleeding. Specifically, we're talking about band ligation and hemoclip placement. These are really the gold standards here. They achieve very high rates of stopping the bleeding initially, often close to 100% in studies, and they have low rates of the bleeding starting up again. Plus, they have good safety profiles. They work by physically closing the tear and compressing or strangulating the vessel underneath.
Let's just talk a bit more about why clips and bands provide better, more durable control compared to just injecting something.
Yeah, durability is the key word. Injection therapy, usually with diluted epinephrine, works in two ways. It causes blood vessels to constrict, and it provides some local pressure, like tamponade. But the effect of epinephrine is temporary. Once the drug wears off, that vasoconstriction goes away, and the vessel can just open up again if the tear hasn't sealed itself. Clips and bands, on the other hand, provide actual physical, permanent closure. The band sucks up tissue, including the vessel, and ligates it. The clip mechanically pulls the edges of the tear together like a staple.
Almost like an internal suture, then. It doesn't rely on the patient's own clotting ability, which might be impaired.
Precisely. The band ligates a good chunk of tissue, ensuring necrosis and control. The clip provides strong mechanical closure, which works really well for linear tears like MWT.
Is there any reason to prefer band ligation over hemoclips or vice versa for MWT specifically?
Well, both are considered excellent first-line options. Some studies have maybe hinted that band ligation might have a slight edge in reducing early rebleeding compared to maybe using clips plus epinephrine. But honestly, in practice, the choice often comes down to what the endoscopist is comfortable with, the exact location of the tear, and what equipment is readily available. The main message is mechanical therapy is superior to injection alone for active bleeding.
Okay, so let's contrast that with injection therapy. When is epinephrine still useful?
Epinephrine injection still has a role, but mainly as an adjunct, something you add on, or as a way to temporarily slow things down. It can be effective for getting initial control, slowing the bleeding quickly. That can make it easier and safer to then place clips or bands accurately, especially if there's a lot of blood obscuring the view. And this is crucial for a tear that's actively spurting or really oozing heavily, epinephrine is not recommended as the only treatment, as monotherapy, because the risk of it starting to bleed again is just too high.
The sources also mention combination therapies, often used if things are difficult or refractory. What does that typically involve?
Combination therapy usually means using epinephrine injection first to slow the bleeding, then immediately following up with mechanical clipping or maybe a thermal method like electrocoagulation. Doing both maximizes the chance of success, especially if the first attempt with just clips or bands was tricky because of the location or how much it was bleeding. If multiple tries with the scope fail, then we think about other options.
And when do we get to that point? When do we decide this is refractory bleeding that needs surgery or maybe interventional radiology?
Thankfully, needing surgery, like actually suturing the tear or even removing part of the stomach, or needing interventional radiology to do an angiographic embolization of the feeding artery, usually the left gastric, that's really rare for MWT. These are truly salvage therapies. They're reserved almost exclusively for cases where the bleeding is catastrophic or just won't stop despite multiple good endoscopic attempts. Or maybe the patient is just too unstable for another scope procedure. The success rate of endoscopic mechanical therapy is so high that this is uncommon.
Okay, so beyond stopping the bleed, what's the key supportive medical care needed afterwards?
Acid suppression is really important. Proton pump inhibitors, PPIs, are standard. They help prevent the initial injury in high-risk folks. And after bleeding stops, they help the clot stabilize by reducing stomach acid. We usually continue PPIs for several weeks after the bleed.
What about feeding? Do these patients need to be kept NPO, nothing by mouth, for a long time?
Generally, no. Once you've confirmed the bleeding has stopped and the patient seems stable with no signs of ongoing hemorrhage, you can usually start thinking about refeeding fairly early. The data suggests that keeping low-risk patients NPO for longer doesn't actually improve outcomes. Getting the gut working again often helps recovery and might even shorten the hospital stay.
All right, let's shift now to those special scenarios and the overall outcomes. Coming back to the patient with active coagulopathy or on anticoagulants.
Yeah, this is a common and tough situation. It really needs a tailored, often multidisciplinary approach. First step is to stop or reverse the anticoagulation if it's feasible. That's a risk-benefit calculation, right? Weighing the immediate bleed risk against why they're on anticoagulation in the first place, like a mechanical valve or a recent clot.
And if they are actively bleeding with, say, a high INR, the intervention needs to be really robust.
Absolutely. For active bleeding when the patient is coagulopathic, mechanical endoscopic therapy clips or bands is strongly preferred over just injection. Like we said, the mechanical methods physically overcome the clotting problem. They provide reliable structural closure that doesn't depend on the patient's faulty coagulation system.
And let's circle back to the hemodialysis patients again. Their management is different, even if the bleed doesn't look massive initially.
These patients are always on a tightrope. Even what seems like a minor MWT can trigger resuscitation efforts that are really risky for them. Because they're prone to fluid overload and often have underlying heart disease, pouring in crystalloids or blood can easily tip them into heart failure or flash pulmonary edema. So their resuscitation needs really careful monitoring, maybe using central lines or point-of-care ultrasound, POCUS, to guide how much fluid you give. You have to keep them stable without overloading their heart.
And for those unfortunate patients who present with truly severe hemorrhage, unstable right off the bat, speed is critical.
Speed and decisiveness. Severe hemorrhage needs immediate rapid resuscitation, and you have to go straight to urgent mechanical hemostasis via endoscopy. There's no time to waste observing or waiting. If someone's in hypovolemic shock from an MWT, you need to get those bands or clips on fast to get primary control.
Okay, turning towards outcomes. What are the most common complications we see during the hospitalization for MWT?
The most frequent one is simply bleeding anemia, needing blood transfusion. That's reported in maybe up to 26% of cases. The more severe complications, hypovolemic shock, acute kidney injury, AKI, and sepsis that follows the shock, those are all consequences of severe bleeding and the body-wide impact. Rebleeding after successful mechanical treatment isn't super common, but you definitely need to watch closely for it in those high-risk groups, patients with cirrhosis or persistent coagulopathy.
Let's talk mortality risk. The overall number often quoted is low, but that hides a lot, doesn't it?
That is probably the single most important clinical takeaway. Yes, overall mortality in big studies is low, maybe around 2.7%, but that number is misleading. Mortality shoots way up for patients who develop those complications, shock, sepsis, AKI, and for those with major underlying problems like cirrhosis, severe heart disease, end-stage renal failure, or just advanced age. For that specific high-risk group, 30-day mortality can easily reach 5 to 10%. That's tragically similar to outcomes for severe peptic ulcer bleeding. It's rarely the MWT itself that's fatal. It's the patient's underlying system being unable to cope with the blood loss and the stress of treatment.
So for most people without those major risk factors, the prognosis is generally good, usually a short hospital stay.
Exactly. For the lower risk population, prognosis is typically excellent. Hospital stays are often just 1 to 4 days, mainly for observation to make sure the bleeding has stopped. Then the focus quickly turns to preventing it from happening again.
What are the key things for long-term care and prevention that need to be addressed before discharge?
Long-term management is all about fixing the underlying risk factors. You have to address what predisposed them in the first place. That means tackling alcohol abuse with counseling and support, aggressively managing any underlying reflux disease, and doing a really careful review of their home medications, especially stopping or finding alternatives for risky drugs like NSAIDs. Follow-up needs to be individualized based on their risk profile and often requires a team approach, maybe involving GI, addiction specialists for those complex cases.
This has been a really thorough deep dive. We've established MWT not just as a simple tear, but a mechanical injury where the severity is driven hugely by the patient's other health problems and what we see on the scope. Let's quickly recap the main points.
Okay, key takeaway 1. MWT is mechanical, caused by pressure spikes, often linked to alcohol or things like hiatal hernia, that classic non-bloody then bloody vomiting. Less common than you think. Diagnosis absolutely needs early endoscopy to see the tear and rule out other problems, which occurred in up to 35% of cases.
Key takeaway 2. Management splits clearly. If it's not bleeding actively or no high-risk signs, manage conservatively, observe, support, use PPIs. But active bleeding or high-risk stigmata, that needs immediate endoscopic intervention.
And that intervention should strongly favor mechanical methods, band ligation, or hemor clips over just epinephrine injection monotherapy, because clips and bands offer more durable, reliable control. And finally, we really have to stress cautious but aggressive resuscitation and careful management of those high-risk patients, especially those with cirrhosis or on dialysis. Their underlying conditions are what primarily drive bad outcomes and mortality.
That really brings us to our final provocative thought for you, the listener. Something that maybe challenges how we approach this sometimes. Given that MWT outcomes depend so heavily on just two main things, the patient's comorbidities, which we usually know pretty early on, and the endoscopic findings of active bleeding or high-risk stigmata, we have to ask, how much extra value do standardized scoring systems really add on top of our initial clinical judgment and just getting the scope down quickly to see the tear? Are we sometimes delaying necessary effective action by focusing on calculating a score when the clinical reality is often quite clear right in front of us?
That's a critical question for practice, isn't it? It pushes us to prioritize acting on the clinical picture and scope findings, especially when we know mechanical therapy works so well, rather than potentially delaying for a score that might not change management much in these cases.